Hello, this is Nancy Reau and Kim Brown, and this is Liver Lineup Updates and Unfiltered Insights. Today, we're really excited to have a special guest, Su Wang. I'm going to let Sue. Why don't you tell us a little bit about yourself, because you're not the standard hepatologist that we invite to a liver lineup.
Sure. In fact, I'm not a hepatologist. So I'm actually an internal medicine doctor who specializes in hepatitis B. And so I run the viral hepatitis center at Cooperman Barnabas Medical Center. I also am the medical director of our Center for Asian Health. And I helped start the Liver Center, where I connect all the pieces of the hepatologists with the imaging folks, with the radiologists and interventional and all that. So that's been interesting. And then on the other side, I'm also somebody living with hepatitis B. So I work a lot with the affected community and have been doing a lot of advocacy in the viral hepatitis space. So that's me.
Yes, well, that is in a nutshell an incredibly productive and important person. So, who has been both an integral advocate as well as someone who's been a really important person for the multiple products that we have for hepatitis B, which is why we wanted you on this program. Just one of the many reasons, because you have been a big part of two different guidance products recently, and I think hepatitis B is one of the places where there's maybe a little more consensus across guidelines than what you think when you first read them, but we have a lot of different tools to help with hepatitis B management. And maybe I'll open it by asking you, Sue, which of these tools do you use, knowing that you've been part of many of them, and when and why do you use them the way that you do?
Great. Yeah, I think it's an exciting time for hepatitis B. I mean, we know obviously there's a lot of drugs in the pipeline and but I think in terms of the guidelines and guidances, we're seeing a move towards expansion. And there are many products, as you've mentioned. So obviously many international liver societies have updated their treatment guidelines. And I would say just kind of historically going back, the recent kind of rush of updates probably started like with the China guidelines in 2022, 2023, and then WHO 2024. I was part of that guideline development group. And then a flurry after that last year, EASL in May of 2025, and then ASLD, obviously, in November, December, and then also, actually, sorry, November, and then December, we had the primary care guidance come up after that. So in terms of, we've got lots of things you can choose from. And I think in some ways it's good because it shows that, I think, there's some discussion like, wow, is it confusing? We have all these different guidelines. But I think it also shows that guidelines can be tailored to our audience, right? And on the regions and like the kind of resources that are available. And right. And that's why we see some of the differences amongst the guidelines. Obviously, WHO is focused on lower middle income countries. And the EASL and ASLD are focused on hepatologists in more resource rich countries. And China is interesting because they have such a large population of people with hepatitis B, and theirs is, simplified down to age 30 and viremia, and so comorbidities. And then our primary care guidance is definitely trying to focus on getting frontline providers to be able to screen, vaccinate, and start that treatment cascade for people with hepatitis B. So I think it's great, and I think it's good that we're having this discussion just to kind of disseminate a little bit more and kind of clarify for your audience in terms of like, maybe which products, which guideline they want to use. And the fact that I think it also shows that, it's not clear like one right answer. And so there is a lot of leeway for providers and physicians to kind of tailor their approach to the patient in front of them.
And thank you, Suk, because this is such a confusing topic, I think. So many people. But, you're in the United States, you're a hepatitis B expert. You've been involved in many of these guidelines in your clinic with your population of patients. Which guidelines do you tend to follow, or do you kind of incorporate a lot? And when you educate others, particularly primary care clinicians in this country, which guidelines do you point them to?
Yeah, it's so and I think for a lot of us in the space, I don't know, speaking for myself and maybe having spoken to a lot of people who do a lot of Hep B care, I think we kind of are able to kind of pull from a lot of the guidelines and kind of pick out like the best stuff for what works for our setting, right? And so I think I definitely pick from ASLD, but a lot from, I mean, this is now primary care guidance. And I was part of another set of like recommendations, simplified algorithm, which was, they sometimes call it the SABA guidelines, which uses age 30 and abnormal ALT in 2000. And you kind of start seeing a lot of these commonalities, right? So obviously, a lot of the guidelines use 2000 and any abnormal ALT to simplify it. And for the primary care providers, it definitely simplifies treatment if we don't incorporate e antigen, e antibody. I still test for it because I want to know what phase people are in, but I think a lot of people are saying, understanding that phase is not necessarily a requirement for treating. And so if we can separate some of those and give the primary care and the, other people who aren't seeing Hep B all the time some kind of quick, quick triggers for treatment. So if the ALT is abnormal and you're, pretty sure it's not, this is the complexity we have now, MASLD, D, right? Like what are the other causes for abnormal ALT? Or if the viral load's high, or if there are any of these other risk factors, age, or if you're looking at family history, right? Then it doesn't matter. You don't have to do that litany test. If you've got like one or two of the other triggers for why somebody would be more at risk of HCC. And I like that what EASL did with their guidelines. They have a whole table of like what are the risk factors for HCC, and that's a nice little reference where you can just say, oh, that would be a reason to start treatment early because that person's at risk for HCC. So those of us in the field kind of have this library of resources now, right? Maybe not sitting all one place, but at least mentally we can say, oh, this fits into this fits into that. ACLD guidelines were focused on 6 PICO questions. So it's not comprehensive in terms of like it doesn't address quantitative surface antigen use, which a lot of us are finding really useful as a tool. And I'm sure you guys are ordering it more now too. And it's they're not clear guidelines on that right yet, but a lot of us are starting to use it because it's practical. So yeah, I'd love to hear what you guys are. How do you approach it, right? With all your patients, because you guys have this, interesting background too.
No, the reason I ask is that, I feel like many guidance documents and now even, the new nutrition guidelines, everyone talks about shared decision making. Everyone talks about, well, if there are additional risk factors for a clinician who might see one hepatitis B patient every 3 to 9 months, right, in their practice. They don't have those things in their brain. They don't have a tool on the wall. They're just trying to decide, do I treat a patient? Do I not treat a patient? Do you think that these guidelines are simplified enough for us to get them into practitioners' heads, people who don't do this every day? That's hepatitis B. When I'm sure when you give talks and I give talks and Nancy gives talks, people's eyes just glaze over. They're like, oh, this is why I did not go into hepatology, because this is way too complicated. So what do you think about that in terms of, those are risk factors, and now we're telling people to understand their own risk factors.
Yeah.
Patients understand them less than physicians do. So
Yeah. Yeah, no, I agree. I think people have this trauma from med school where they see the squiggly lines, right? The viral load, the ALT, and then they're just like, oh, this is specialist matter. And we're trying to explain to people, no, 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 we need you to kind of step in. Otherwise, we're never going to get to viral hepatitis elimination if we only think of this as a specialist disease because it's so common. And a lot of people cannot make it to see hepatologists like you. So, and we are the ones that need on the front line who need to start the screening and the vaccination and at least some of the initial testing. But yeah, so I think I agree. I think um, the hepatology guidelines are a lot for patients. I mean, for physicians to digest and get a lot of the nuances. The primary care guidance, which is hosted on the University of Washington website, is great because there is, and my favorite product out of the whole thing is like this one pager that we developed, and Nancy's seen it, and that is something you can print out, post somewhere or keep a screenshot of it somewhere, but it's got like, what are the screening tests, right? Because we know often there is confusion on, do I need to do the e antigen for the screening? You do not. And even confusion like the core antibody test, right? A lot of times, and unfortunately, the test panels often include IgM when really you just need the IgG or the total for screening for chronic Hep B. And then it's got the table of interpretation, so you don't have to go Google it every single time. What the tests mean, and then a summary of the vaccines to recommend and the spacing and the vaccines that are out there, and then initial tests to order. And then it has like treatment indications, and it breaks it down just to like four indications. And one of them is the lab. It's looking at ALT abnormal and viral load over 2,000. And then fibrosis. So, looking at somebody with significant fibrosis. And we do have options for using elastography or APRI or FIB4. And then third is like comorbidities, somebody with HIV, although they would, we would send them to infectious disease. But other things like family history, and we incorporate in that like somebody with high viral load, who's pregnant, by over 200,000 if they're pregnant, or a high risk of transmission, which is new in the ASLD guidelines, as you guys know. And then lastly, which I think is important, is an option that if a patient prefers treatment over monitoring, that alone would be a reason. And I think there's been so much discussion about this that, in this set of guidelines for ASLD, and I don't know that it's really obvious when you read it, but if you've heard any of the people like Nora and even Mark, when they present about it, one of the things that we'd really wanted to shift from the previous set of guidelines is that nowhere does it say like there's a group that you cannot treat, right? So we're trying to make it so that potentially anybody with hepatitis B could be treated. And EASL is very clear about that in their guidelines. It says in theory, anybody who's surface antigen positive with viremia is a candidate for treatment. Obviously, the risks and benefits depend a lot about viral load and ALT specifically, but other risk factors. So I love that. I think that's a big shift that we should make sure is out there, that people are, and that's where the shared decision making comes in, right? So I agree that the word is probably thrown out there a lot out right now, and some of it is not in a good way, because I think we've heard a lot used in vaccination. And I think it makes sense if it's an equivalent choice that you have for a patient, like the risk benefits are equivalent. I think for vaccination, I think most of us would say Hep B vaccination, like it's a clear benefit over risk, but unfortunately it's been used as equivalent in shared decision making. And so I think for Hep B, like what ASLD did is use shared decision making for certain scenarios, for indeterminate, for the horizontal transmission, and e antigen positive, where it's not clear, then you can still offer it and discuss with patients. So, I think from the affected community, there was a really good survey done before the WHO guidelines. About 500 people with Hep B answered it, and it was really eye-opening because about half of the people who responded said their doctors never even mentioned to them that there was something they could take for hepatitis B. And so I think that's a failure on us, right? We've already made the decision for the patient. We already told the patient, you don't need it, or we didn't even say, we just didn't even offer it to them, right? So they're not even aware. So I think that's one thing we have to do on our side, is to at least inform patients that there are medications that can treat them, and then go into, why, my recommendation, whether I think you may or may not need it based on recommendations. And then the third step, when we talk about shared decision making, is then elicit or ask the patient to participate and ask them, what their preferences and values are. Like, do you want to be proactive and want to take medication? What we see a lot of patients do is when the doctor says there's nothing for you, they will go out and buy herbal medicines, right? Or something that we know does not work. So, logically, it doesn't make sense. Why am I letting the patient buy something and spend their money on something that is not effective, where they could easily take something that works well and, is affordable now because it's generic? So I think those are things we have to at least present to the patient, ask them what they want to do. And when they want to be proactive, then they have the option to take it. Or some patients, as you well know, don't want to be on medicine unless they absolutely have to, right? So it's helpful for us to ask the patient what they prefer. I think a lot of us physicians feel like we're already doing that, but I think we're not explicit enough about it. And this is where we can do a little better with that.
Yeah, I mean, I think that one of the struggles, especially in a busy clinic, and I would say even in hepatology, people are still sometimes uncomfortable with hepatitis B. I mean, you see mast cell all day long. You might not see a lot of Hep B if you're living in an area where it's not as frequent.
Mhm.
I don't think we do shared decision making very well at all because it takes time, and we probably don't want to go through the steps that are required to empower a patient to feel like they have the ability to contribute to the decision process. Or sometimes even the patient's, you know, desire to take something herbal or all natural over something that we think is probably better is just frustrating. And so we don't go through that conversation.
Mhm. Yeah. So I think one thing that will be important, I think, are tools. So beyond the guidelines, what else can we do to help facilitate this? Right. Obviously, it is time consuming. And so, we are hearing of, like many of you know, Patrick Kennedy, he's developed a app called Hep B and Me that patients can use themselves and kind of walk through the steps and see where they fall kind of in the risks. And then so education is key, right? So obviously, educated patients are really helpful in terms of that partnership, right? Because then they were kind of understanding what we talk about when we talk about risk factors. And then at my clinic, we're actually piloting a survey on shared decision making. We're calling it Be Smart, and I'm hoping once we get through a pilot phase, we can release it widely. But it specifically looks at PRO, so patient reported outcomes, and it asks, how does Hep B impact your life? Is it nothing or is it a lot? What are some, what are some symptomology you might feel? So, because one of the things that I think traditionally we have thought that unless you're cirrhotic, Hep B is silent, that it's asymptomatic, right? That's our understanding as clinicians. But when you look at, I mean, years and years of studies in looking at patients, like there are things that, like fatigue, is one of those things that we see a lot reported in surveys from patients that are not cirrhotic. And I think there's more recognition of PRO in other disease states, right? Like cirrhosis, and other liver diseases. And I think we got to listen to the patients, right? PRO is really supposed to be unfiltered, like what is the patient's experience of the disease? And the Hep B Foundation has done a lot of great work in this area, really studying this. And they've looked at it in different, like certain domains are really coming out. So fatigue is this one thing. Also worry and anxiety, which have, the psychosocial realm, as many of us know, is much larger than a lot of the physical symptomatology. But it's the worry and stress of having something that you could die early from, from liver cancer. There's self-stigma, just feeling like you're somebody who's infectious and, um, you know, you have a virus and you have to stay away from people. Like we see that a lot. Like there's this people isolate themselves and there's depression that happens and definitely, reports of people being suicidal and, it can completely change their future and how they, whether decide to pursue certain careers or go to school. And these are things that are important for us to recognize and not only focus on the liver, but focus on the whole person. So our survey looks at, how much it affects people's lives. And then we kind of walk through what's important for you. Like, is in terms of how you perceive Hep B, what's important? Is it important that you reduce your risk of liver cancer and cirrhosis as much as possible? Or is it important for you not to take medicine? You worry about side effects. It's important for you to be proactive. And then we have them rank it. And this is something we learned from a Hep C PCORI study that was done. And it was really interesting. Like, yes, people were really concerned about liver cancer, but they were also really concerned about how much the medication was. Because that's the day-to-day thing that's more important. That's more important right away, as opposed to something that could happen decades down. So we had them rank it. And then we have a table where we go through the labs together. And this just basically has it simply broken down to like normal or abnormal, like normal or high. and then they can visually see like where they fall on that. And then we walk through like, and this is something that why we actually give to the patient before the doctor even sees them. So you're not sitting in the room, waiting for them to fill it out, right? Because that's the time thing. So they sit there and they fill it out before I even see them. We go through the labs together, and then we walk through like that. Then most of them actually have read through the whole thing before I even go in. And it says, do you know that there's options for you for Hep B? This is what the treatment does. You do have to take it every day. You have to be compliant. And then it asks, where do you think you are? Do you feel like you would be interested in this? And they say, yes, I'm not sure, I have some questions, or I'd rather be monitored. And then we talk about, the confidence of taking medication. Obviously, one of the big concerns I think a lot of the provider community has had is like, can patients be compliant, right? This is a daily medication. And often that's used as an argument for why we shouldn't, recommend treatment. But I think it's really important we put that out to the patient, right? Let's not decide for the patient, like, I think you're not going to be compliant, therefore I'm not going to recommend it, because that's very paternalistic. But let's help them be adherent if we recommend it, and let them know, like, this is what's required. So we go through that. And then for the patients already on treatment, there's a survey that also looks at PRO, because we want to know if there's any differences between people on treatment or not. And then we go through a bunch of questions on treatment adherence. So like, are you missing your medications? How often? Because I think that's an important component for, chronic care medicine. So anyway, that's that in a capsule.
No, I think that that's great. And I think that all those tools, I mean, part of having a tool that works is also making it available to people. And so that, the fact that there are these things that are housed in places that are readily available, we just have to get them to the people who need them, is really important. And we're hoping that we get the Be Smart. You did say something about like using the PRO that was modeled against Hep C. I think we forget. I mean, on tests, it's very easy to remember that there are extrahepatic manifestations of Hep C.
Yeah.
There's always going to be a test on like, rash,
Yeah.
kidney failure. But almost all of the extrahepatic manifestations that we readily associate with hepatitis C were first documented in Hep B. And when you look at hepatitis B and things like, rates of diabetes, rates of metabolic abnormalities, they're higher in our patients that are infected. Which leads me, before you and Kim respond, to go back to one of the things that you said that really is like, if your ALT is abnormal with MASL, that makes things confusing. But the WHO and I think EASL guidelines really pulled in the fact that if you have metabolic risk factors, that you should treat your Hep B. Maybe your ALT is elevated from steatosis, but that doesn't mean that your risk is identical to someone who has just steatosis, and that modifying the Hep B risk is something you might be able to do than to fully modify the MASLD risk. So that table that's in the EASL guidelines, or that table in WHO that brings in things other than just family history of cirrhosis and cancer, and I think kind of, pulls in that that this is not something that you want to monitor if you have these other comorbid conditions.
Yeah. Yeah, no, the WHO guidelines are distinctive in that, saying that if you have diabetes or MASLD, that alone can be a reason to treat hepatitis B. And I think especially in areas where, viral load is not as accessible, like in some areas you can't even get a viral load test, a Hep B DNA test. It's interesting with WHO, you can treat just based on ALT alone. So, we're just trying to get people, closer to be able to initiate treatment, and especially in high burden areas like Africa, where there's such a, high burden of early liver cancer, especially in young men, that if we can get them, the treatment is often cheaper than the viral load test. So I think, those are things that factor into, what the WHO guidelines say. But I think is important is, there's access issues in the US too, right? We all know that not everybody has easy access to testing and to specialized care. So it's, I talk about the WHO guidelines, in the US as well.
Can I ask your opinion? You talked about us as physicians, being paternalistic to our patients. Do you think us as a community have been paternalistic to our physicians? Because the complexity in these guidelines really, I think, put fear into our clinicians as to if they were doing something wrong, right? I'm treating a patient who couldn't be treated. And I feel like we're moving, hopefully very slowly, but hopefully away from that, where we're more trying to empower clinicians to treat as
Yeah.
opposed to tell them and restrict them from treating. What are your thoughts on that?
Yeah. Wow, that is such a powerful view, Kim. And I think like I've never heard it said that way, but I do feel like the restrictiveness is something that has been concerning. And when you hear from patients, like patients that are really kind of activated, they often are pleading with us, like, why are you making it so difficult? Like, if something works and it's cheap, and like the question is, you treat it as if it's harmful to us, right? You hold it back from us, like, oh no, I can only give it to you if you make meet this and this criteria. And then what happens if I don't and I start the medication, right? And I think we haven't had a good answer for people, right? I think we say, oh, but then you're on medicine for the rest of your life and you might flare if you go off. And for patients, that's not convincing, right? Like that's an issue that's not a real issue about like whether that medicine is harmful for me to start earlier, right? Which I think is the crux. And for me as a patient, I had that very same question when I was deciding to start there because I didn't meet the criteria strictly either. And I remember going around asking different specialists, and I remember thinking, oh, I put them in a really uncomfortable spot. Like they're really getting squirmy when I ask them this question. But then when I hear people say, and they say, well, if I was a patient, I would start treatment. Then it's like, whoa, like you think that? Why would you make it hard for a patient to have that exact same option? And I think there's things that we know about Hep B now that are not reflected in our guidelines that just because the way we do guidelines, right? So we know about integrated DNA, we know about the mutations, we know about T cell exhaustion, but those things do not get factored into our guidelines just because the way we do guidelines, right? We look for interventions and outcomes, on patients, but we're not looking on, on the micro level virology. But hearing all that, I think when I talk to a lot of educated patients, they often are like, oh, yeah, and they choose treatment, right? Because they've heard enough of all the great science that happens at AASLD and other meetings. And I feel like we got to listen to them. Like, if that's concerning to people, then, for our patients that don't have access to that, like, they should also be allowed to, access treatment. And Kim, I think you're exactly right. There was actually a podcast this Curbsider podcast, which some of you may have heard of before. These are like the smartest internal medicine doctors out there. And they interviewed Arthur Kim, who was on the guideline committee too. And they talk about Hep B and at the end of it, they were like, that's great, Arthur. We're going to send you all our Hep B patients. This is like too much for us. And I was like, no, that's not the message. Like, we're trying to make it so that, you guys are smart and you treat the most complex internal medicine. Internal medicine is complex. As a primary care physician, I manage diabetes, I manage heart failure, hypertension, I manage like a lot of interactions. And so for us to say, that a primary care doctor cannot manage Hep B, which is only 3 oral medications, very limited doses, very little side effects, very little interaction with other medications, doesn't make sense to me when I'm managing diabetes with like 20 medications, injections and orals and lots of side effects. And I don't feel that like fear, like you're saying, like, oh, I might be doing the wrong thing. Right. And I hear that a lot, right? People don't want to be thought of as doing the wrong thing for
Right.
patients. And so how do we change that, Kim? I think it's really interesting that we have been paternalistic to the treating community. Right, how do we get that out so people don't look at the really complex diagram and say, "Oh, no, this is too much for me." Like, "Oh, that patient didn't hit the 2,000, 20,000 mark, and therefore, you're not allowed to take medication."
Right.
But if you think about it, again, not to go back to Hep C, but when we moved from complicated therapy that really no one wanted to give to all oral treatment that everyone should give, I think that hepatologists maybe not all of us, but some of us felt that we were losing something that we owned, right? That you should be a subspecialist to treat Hep C because even though it's not complicated, it's still Hep C, and it used to always be our world. And it's a little bit of what I describe now with oncology. I mean, I think that some of us need to claw a bit of our oncology away from the oncologist because they're not always readily available. And, we need to have more practitioners that are empowered to treat things that are in our office and not have these, delays in the care cascade while you're trying to wait on a certain provider. But, I think right now we're pretty comfortable having primary care and addiction medicine, like anyone treat Hep C, because we've finally admitted that it's really not that hard as long as you don't miss cirrhosis and you don't, miss something that's going to increase the risk of the patient. We need to start being a little bit more honest that a lot of Hep B follows in the same, pattern, that it isn't owned and nor should it be owned by a subspecialist or a subspecialist. You don't have to go to an infectious disease doctor or a gastroenterologist or a hepatologist to follow something like the SABA guidelines that you talked about. Um, I still think the ASLD guidelines are a little bit complicated. I know, Sue, that we look at that ability to add shared decision making and the fact that we're more generous with the indeterminate or the gray zone. But I've been lecturing on the new guidance and what the differences are between the old one and the new one, and it's still really complicated in there. That table is not easy.
No, it's not. And I think, there was a lot of discussion about whether we still had to phase people, right? Because if you have to figure out, are they immune tolerant? In order to determine somebody's indeterminate, you had to first decide whether they fell into one of the buckets, right? And so it's a multiple step process, which I think, can be cumbersome for people. But, I think when you are coming from like a hepatology viewpoint, obviously you want to provide people the best care, right? So I think for the hepatologist, this is the best care for patients. But for other people, it's like, well, you're getting best care for a few people, versus like, can we get decent care for like more people, right? So I know I've used this like metaphor for people. It's like if we could only get a baguette at a bakery, right? Very few of us would eat baguettes. But thankfully, there are baguettes at a regular grocery store. So and they may not be as good as the bakery, but they're pretty good, right? So like, hey, let's like expand the offering so that more people can get good care. It doesn't have to be perfect care, but at least they can get, good care. At least they're getting the thing, the product, which is, treatment, which we know works and really helps, reduce the viral load, which reduces inflammation and transmission. So I agree. I think, it was as with any sort of guidelines, it's a push and pull of a lot of different factors and interest. And so moves us a little bit. I think we have a lot more to move, and maybe as we get more therapeutic agents, right? I think that's what people are hoping, then we will be forced to kind of move it along a little bit more. But I think it's helpful for people to hear what you just said, and I don't know how we get this message out, right? That's the key, is like there's a message behind this set of guidelines, and it may not be like official, but it's like the sentiment that a lot of us, do agree with. And I would say a lot of people who are involved with the guidelines will not necessarily practice exactly by those guidelines. How do we get that out there as well? Because I hear that. I hear that a lot of the hepatologists actually do it a little bit different. And so, that's the trick. So yeah, this kind of venue is helpful too.
Can I ask, Sue, do you think the Chinese got it right? Do you think that, they have simplified their guidelines to the point where virtually anyone can do this and virtually anyone can feel confident that they're doing it right? They're following whatever that guideline is. Do you think I feel, having been in this game for a long time, that all of us are moving more in that direction in terms of just bringing more people into care? And tell me what you think about those Chinese guidelines.
Yeah. Yeah, and they came out before anybody else. They came out in I think they were published in 2023, but they were, yeah, so that's before all of this other stuff has happened. And APOSL guidelines are coming out in April. So it'll be interesting to see what theirs are. But yeah, it definitely simplifies it in terms of, it's, and some of it has to do with the setting too, but like viremia age 30, and it is a little bit more nuanced than just that. If you look at it, they look at fibrosis and family history as well. And then I didn't mention it, but I think it's important also that our Hep Foundation, which represents patients in World Hepatitis Alliance, also during this time came out with their own statement. So World Hepatitis Alliance came out published a statement about, we need to be at treat all, we should be offering everybody treatment. And then Hep Foundation has something that basically very similar to China, and actually they pull from the Chinese guidelines as a reference that viremia over 30, the patient wants it, and then, some of the other indications. And I think what's important, it says, we're not using this to replace the other recommendations, but we think it's important to have something that catches people who fall through the cracks, right? We want this to bolster the guidelines that if you don't fit there, that it is okay, like you're saying, it's permissive that, that there are other buckets that people can be treated. And 30 is easy to remember, and it makes sense, right? Because people most likely have been living with chronic Hep B for decades at this point. So you are at a higher risk. And I think the reason we don't have a lot of, convincing outcomes is because we don't have any good cohort studies of hepatitis B that follow people that long, except for the Alaska cohort. So, I think it's important for us to, factor that in to the risk factors. And the ASLD only does it, I think, for the immune tolerant. And, it's kind of in there, but it's not super clear that you could just treat, just based on the age too.
Well, but I mean, if you come back to age, there isn't consensus for 30, and I think ASLD still uses 40, right?
Yeah.
And I think is it EASL that is 35? So that I like the 30, because as when we lecture about this, it's really important to emphasize that chronic hepatitis B is a pediatric disease. You do not get this when you're a teenager or when you're our age. You get this when you are born or when you're growing up in a household that has hepatitis B. And so that you don't want to just treat it at a time when someone is viewed as an adult or an old person.
Yeah.
You really need to move that needle down to something that's not as stigmatizing and doesn't bring in the context of high risk behaviors.
Right. I think the question is, are we treating to prevent inflammation once we see inflammation? I mean, are we treating to prevent liver, end stage liver disease once we see inflammation, which I feel like has been the traditional view, versus like, can we treat to prevent even the inflammation, right? Like prevent the fire rather than just put the fire out of the house. And so that's a little bit of a difference of approach, but I think we should be allowing people to treat to prevent the fire, right? And so I agree, it's pediatric, yeah.
I think we here in the United States focus so much on the inflammation, right? And the risk from inflammation and fibrosis progression. But what about integration, right?
Yeah.
And integration relates to time. And that's the thing that, I think we're teaching differently now, right? It's both buckets. It's the integration, but it's also the inflammation. And so using ALT, for example, you're only really looking at one aspect. I think looking at age, you're moving toward looking at integration.
Yeah, that's a really good point. And so the Hep B guidelines do say that treatment as prevention should be its own reason to treat. So we think about it as treatment to prevent liver cancer, but also treatment to prevent, inflammation or transmission as well. So yeah, that's a great message.
Well, Kim, I know that we are both really excited to have had Sue talking about the various guidance, the importance of shared decision making, the fact that we really do need to be able to both empower our patients as well as our providers that do not feel that they're Hep B specialists to feel that they are active participants in not just screening and referral, but actually screening and initiating treatment for hepatitis B. And we look forward to the ongoing evolution of our guidance tools, especially as these new therapeutics start to become available to us. So Sue, thank you very much.
Thanks so much for having me. This was great talking with you too.